So welcome. My name is Guilherme Couto, for those that don't know me yet. I will be moderating this first webinar that is organized by the Society of Medical Radiographers in Malta. This webinar series is aimed at celebrating the Radiography Month, and it aims to share some research, some lectures, to start some discussions that are relevant for our profession. In today's webinar, Mr. Claude, Portanier, Mifsud, Dr. Frank Zarb, and Ms. Sarah Farrugia will be talking about clinical audits and how this is important in radiography practice. Okay, this is our first time using SRM Zoom webinar platform, so please be patient with us because sometimes we may struggle finding the correct buttons, but we will make sure everything goes as planned, or we'll try at least. I mentioned it before for those that were here before, but we can communicate in two ways with the attendees. We're not hearing you and we're not seeing you, even for privacy reasons, because this is a webinar platform of Zoom. And you can communicate with us in two ways. You can either use the chat or you can use the Q&A button, okay? The Q&A button is going to be used specifically to address the panelists. So if you have questions, you can use the Q&A button. If you just want to discuss something, please feel free to use the chat. Okay. Basically, that's it. So you can even ask questions even during the presentation, so they are going to be saved on the Q&A. And then at the end, when all three panelists presented, I'm going to go through the Q&A and ask and address the questions that you asked. So without further ado, the first panelist is Mr. Claude Portanier Mifsud. He's a diagnostic radiographer at the medical imaging department at Mater Dei Hospital. Thank you very much for accepting to present. And I'm going to pass the floor to you.
So thank you, Guilherme. I'm going to share my screen with you so that you can see the presentation. Okay, I hope you're seeing it. So today's topic is clinical audits. And usually when we hear the word audits, we associate the word audits with, it's quite of a negative connotation, because audits are usually associated with finger pointing, with focusing on someone or focusing about a problem. But I think the idea of this presentation, actually the idea of this presentation is purposefully to change this idea and this negative connotation. So when I was actually planning this introductory presentation, I went into the Google. I Googled what is the role of the radiographer, and several definitions and several roles cropped up on the Google. For example, radiographers today play a pivotal role in the diagnosis of disease and are responsible for the examination of patients using radiation, ultrasound, and magnetic fields. So the question I think we have to ask is, are we using radiation correctly? Can we use it better? Are we using the maximum potential of our equipment? We also, as radiographers, are expected to apply our knowledge to assist in the diagnosis and treatment of patients. So again, the question, are we applying our knowledge to assist in the diagnosis and treatment? Are we keeping updated with new ways of diagnosis and treatments? As radiographers also, we are trained and expected by healthcare systems to provide quality patient care. But are we providing quality patient care? Can we improve on the patient care given? Are we aware about the patient care being given, or we assume that we are providing good quality patient care? We also administer radiation treatment and produce images of body structures for the diagnosis and treatment of injury and disease. But are we following international standards with regards to radiation usage, radiation protection, reduce radiation exposure? Can we improve our images? Are we optimizing our images to use the least possible radiation? to utilize the least injected contrast agent, to protect vital organs to unnecessary radiation. We are also expected to keep up to date with the latest technological advancements and techniques available. But as radiographers, are we keeping up to date? Do we undertake CPD? In practice, do we adjust our techniques based on the latest evidence best practice? And I think the key word here is that we assume. We assume, for example, that we're using radiation correctly, that we're using the maximum potential of our equipment, that we're giving good quality patient care, that we're using the least possible contrast dose, radiation dose, and that we're using the least possible contrast agent. We assume that we're obtaining images while protecting vital organs. And I think that is the key word. We assume too much. In fact, Edwards Deming, a management guru of the previous century, had stated that without data, you're just another person with an opinion. And the idea of these audits is that we change our attitude from having an opinion to having hard facts, so that then we can actually take decisions based on those facts. So as I said initially, clinical auditing is not a finger-pointing exercise. Actually, it's a way and a means how we improve our quality service. So whilst I was actually preparing for this presentation, I noted down some auditable areas in Radiographer, some ideas where we can actually do audits. Obviously, there are much more, and each particular area in Radiography will have its own particular focal points for audits. For example, patient satisfaction surveys are audits where we actually can measure patient satisfaction to see if we are actually satisfying our patients. Audits of complaints, we can see and audit the number of complaints we're having. Where are the complaints occurring, which particular area of radiography? Image quality, are we reaching those image quality criteria? Reject analysis, how many rejects are we having? Which body part is having a lot of rejects, or which particular area within the department? Movement artifacts. Recalls, why are we having recalls and how many recalls are we having? Examination times, are our exam times shorter than our standard accepted time or longer, for example? How long are our patients waiting from when we receive the request to when they are being examined, for example? Our protocols, are we auditing our protocols? Are we updating our protocols depending on latest evidence-based research? We can audit and assess radiographers' knowledge on MRI safety or radiographers' knowledge on radiation protection techniques. Incident reports, for example. How many incident reports are we having? Are we under-reporting or are we over-reporting? And what type of incidents are we having? And also CPD. Are we performing enough CPD? Is the CPD related to our area of interest, into our area where we work? Quality of care. The basis for all audits is basically assessed on three main components: patient safety, patient experience, and the effectiveness of care. So basically, when we're doing an audit, we do it independent from the rest. Just to give you an example, if we're, for example, auditing chest x-rays to see the quality of our chest x-rays, we can actually find that the quality is excellent. And if the quality is excellent, we assume that the radiologist which is reporting on that x-ray, on the chest x-ray, will issue a good report. And if there is a good report, we assume that the treatment of the patient will be good. So we can say that we have good effectiveness of care. But if we then find out that in order to get that excellent chest x-ray, we had to take 5 other chest x-rays for the same patient, that means that patient safety has been compromised and that the patient experience was a bad experience. So when we do audits are independent from the rest, but but we have to look at the holistic big picture, taking into consideration the other components. So who will take the lead? Will this be forced on us by radiologists or by management? Will it be reactive approach, or shall we as professionals be proactive approach, take a proactive approach, and we will be taking the lead in performing these audits? Another approach is that we have both management and us professionals taking the lead. Again, a proactive approach in clinical audits. So what should be our ultimate aim, our commitment? We should strive to provide better and improved patient care. One of the ways of doing this is by doing clinical audits. So what do? We have to audit a particular area, see where we are not reaching our standard, then introduce intervention, doing something to improve the situation, and then re-auditing in order to see that the intervention has actually had some particular effect. And in this way, our commitment as radiographers and as Society of Medical Radiographers will be aiming to deliver a high quality service to our patients. So that was my introductory presentation. Thank you for listening, and now I will give the mic and the screen to my next colleague, Mr. Frank Zarb.
Okay, Frank, I don't know if you're talking, but if you're talking, we're not hearing you.
Okay.
Okay. Now we're not seeing.
Now, yeah, I'm sharing. Okay. Sorry about that.
No problem at all.
So, first of all, I would like to thank the SRM for inviting me to deliver this presentation on clinical audit. And I think my presentation is going to lead on to what Claude has just presented. First of all, the objectives of this presentation is to understand the concept of clinical audit under the scope of the European Directive Basic Safety Standards. The European Directive, which before was Euratim of 2013, entered into force on the 6th of February 2014, and in Malta was brought into force on 6th February 2018. The basic safety standards for protection against the dangers arising from exposure to ionizing radiation merged together 5 other different directives which were issued by the European Union. So now these were merged into one. The Basic Safety Standards Directive focuses on the maximum permissible dose which is compatible with adequate safety. So the directive emphasizes the need for justification, that is, there needs to be a valid reason for medical exposures. It lays down uniform dose limits for this purpose, that is, it establishes diagnostic reference levels, and calls for the application of the optimization principle, that is, to keep radiation doses as low as reasonably achievable, better known as the ALARA principle. Within the directive, Article 58 obliges all member states to carry out clinical audits in accordance with national procedures. And the directive defines clinical audit as a systematic examination or review of medical radiological procedures which seeks to improve the quality and outcome of patient care through structured review, whereby medical radiological practices, procedures and results are examined against agreed standards for good medical radiological procedures, with modification of practices where appropriate and the application of new standards if necessary. So as you notice in this definition, I highlighted the key words. Clinical audit is a systematic examination. It needs to be done in a specific way, in a scientific way, not arbitrary. The main reason, as Claude pointed out, is not to point fingers, but to improve the quality and outcome of patient care. That should be the ultimate goal of a clinical audit, where the results of the audit are examined, are compared against agreed standards for good medical radiological procedures. So we need to compare the findings of the audit with approved good practice. Based on this comparison, then we need to see whether there is a need for modification of practice. So we need the intervention, as Claude pointed out, the intervention to modify and improve our practice. So the clinical definition, the definition of a clinical audit, what is a clinical audit? Basically, it is a way we can check if we are working up to good standards. The main basic functions of a clinical audit are to evaluate the current status of the healthcare unit or the service being provided. So we evaluate our performance. And secondly, to identify areas for improvement. That is, we try to make things better. So, clinical audit is a systematic, but also a continuing activity. It is not something which we do once and forget about it, but it is something which we refer to over and over again. Because with a clinical audit, the outcome of that audit, there are recommendations, and we need to implement those recommendations. A clinical audit is carried out by auditors. Who are these auditors? They should be persons who have extensive knowledge in the field. And in our case, they should have experience on radiological practices. The clinical audit should be comprehensive. That is, cover the entire clinical pathway in radiological practices. Claude had a list of possible audits which can be performed, but that list should be exhaustive. But at least we should start. We should start by simple audits, and then the audits are expanded as part even of a quality assurance program, in order to comprehensively, totally cover the entire radiological practice. We need to be looking at structure, process, and outcome. With regards to structure, we need to have clear lines of authority. People need to know clearly what is their role, what are their responsibilities, and the settings in which these occur. In terms of resources, do we have enough material resources? Do we have enough human resources? We need to know the organizational structure. To whom should we report? So there should be clear guidelines. The process. What is actually being done in giving and receiving care? Are we performing justification, Are we performing, do we have a good referral process? Are we optimizing our procedures? Are our patient doses and assessments of image quality satisfactory? What are the practitioners' activities? Then we look at the outcomes, the effect of care on the health of our patients. And again, as Claude mentioned, he mentioned as an example, the degree of patient satisfaction. But patients, we need to keep in mind, yes, patients are important and they should be the focus of our service, but patients aren't our only clients. We also have referrers, we have radiologists, we have consultants. They too are our clients. So we should not just focus our audits on patients and the needs of the patients, but we have other clients and we also need to cater for their needs as well. So we also mentioned that the findings of a clinical audit should be compared to standards of good practice. And these should be based on legal requirements, the results of research, evidence-based, recommendations by learned societies, consensus statements, and local agreements. So the clinical audit should promote the development and use of international standards of good practice, which should be updated, reconsidered from time to time, because these depend on developments of research and findings of research, that is, they should be evidence-based, and developments, they should be updated with development of radiological equipment. We know that technology is developing at a fast rate. So with that rate of development, we also as radiographers should also develop and improve our radiological techniques depending on the equipment and the type of technology which we are using. Standards of good practice should be suitably written for good practice and they should be made available for assessments. So what is the role of professional and scientific societies, such as the SRM? The role of these societies is to develop the criteria for good practice for the evaluation in clinical audits. They should provide advice, they should provide the stimulus, and also support the establishment of appropriate clinical audits. They should also provide practical solutions on how to carry out clinical audits. We mentioned that a clinical audit is a continuous cycle, and we call this the audit cycle, which should be carried out regularly in order to first select the standard of good practice, then evaluate and assess the local practice, compare the findings of that assessment, that evaluation with the identified standard, and if necessary, and this is very important, implement change. Then re-audit after a certain time in order to identify the impact of that change, giving reassurance that good quality is being maintained, and also ensuring improvement in the service. There are basically two different types of clinical audits which can be performed: internal audits and external audits. Internal audits are usually carried out as part of quality assurance procedures. They are self-assessments. That is, they are being organized from within the department. The first priority is to gain experience in conducting audits. They also provide motivation for performing audits. So as Claude pointed out, finger pointing is a negative attitude. It's not going to motivate the implementation of audits. The implementation of audits is to improve the service. Also, to identify areas which need urgent improvement. And as a preparatory phase for external audits. And now we go to the second type of audits, external audits, which are carried out independently by an external auditing body. And this assures good practice. Why? Because it provides a broader perspective of the service being provided. And especially we here in Malta, we are a bit limited on our exposure to certain procedures and to certain techniques and to certain developments in technology. So having someone externally auditing our processes is beneficial for us to improve and move up the standards in our services. So an external audit also compensates for the limitations, the weaknesses of internal audits. They also judge consistency of procedures. That is, that the procedures are always carried out in the same way. They encourage a more systematic approach to procedures and improvement of practices based on guidelines, especially international guidelines. The frequency of clinical audits. Internal clinical audits should be a continuous activity, as already pointed out, with the aim of having significant parts of the overall audit program covered once a year. We need to try to aim to have a holistic audit program within the department, reaching each area and providing for the needs of all our clients. So at least once a year, we should have an internal audits, not just one audit, of the different components of the service being delivered. External audits may depend on the local infrastructure and the intensity of other quality review activities, but a minimum frequency of once every 5 years. And this should be performed, as I said before, by an independent auditing organization. Shorter intervals can be justified, and extra audits are recommended whenever there are major changes, such as changes in installation, changing equipment, or changes in operation, in the delivery of a service. So we would need to audit the new service or that change. The conclusions from a clinical audit. The conclusions would offer an insight as to whether there are any deviations from good practice, from the standards which we have been comparing our findings. So there could be no significant deviations, meaning that we are conforming to the criteria, to the standards of good practice, good. Or there could be minor significant deviations, meaning that there are areas which have been identified which need improvement. But these could be resolved with the current resources. That is why they are considered as minor. But we could also have major significant deviations, meaning that major problems have been identified, and these require external input in order to solve the issues. So then resources need to be made available. In conclusion, radiographers have an important role in ensuring that audits are performed and that the recommendations from those audits are implemented. And again, I'm going to refer to what Claude said, who should be leading the audit? As radiographers, are we going to wait for this to be imposed on us, or should we be leading it? Another important role is for radiographers to use appropriate protocols and techniques, and that is why we need to be updated in the developments taking place in the radiological and radiographic community. Performing quality control tests, interpreting the results of these tests, recording the tests, and also to undertake additional educational courses in terms of CPD, if and when required. We need to keep the service updated, but to do so, we need to update ourselves. So that is what I have to say today, and I thank you very much for your attention.
Thank you very much, Frank. Last but not the least, we have Sarah Farrugia. She's also a radiographer at Mater Dei. Again, thanks a lot for accepting to present. Sarah, I'm going to pass the floor to you.
Thank you very much, Guillaume. So today I'm going to present my audit on MRI sequence repetition for subject motion artifacts, which I had performed with Dr. Veronica Aquilina, who is not here today. So, motion artifacts are voluntary, such as a patient moving his hand or leg, or involuntary movements, such as breathing or pulsation, passive pulsation, that can compromise the image quality, and therefore this may interfere with the image interpretation. In MRI, this is manifested as ghosting, which are low-intensity copies of the original image shifted in the phase encoding direction, or as blurring, which is defined as diffuse image noise all over the image. As you can see, here are some examples of ghosting and blurring. On the left of the screen, we can see ghosting, and as you can see, there are the copies of the area imaged in the phase, copied in the phase encoding direction, and blurring on the right of the screen, where the image is blurred all over. The aim of this audit was to evaluate the repetition rate of the sequences performed in our usual scans, and how many of them are being affected, have motion artifacts, basically. And the second aim was to implement a protocol which was aimed to guide the radiographers when there is motion artifact, and to assess the adherence to this protocol. And the target of this audit was that we have 100% compliance to this protocol. We analyzed 100 outpatient cases for each part of the cycle, of the 3 cycles that we performed. I will explain later. Each of these 100 cases were either MRI brains, knees, or lumbar spines. This criteria was set because to have a more homogeneous sample population, and because the scan areas included have a low intrinsic motion. This data was collected retrospectively from 4 random days for each part of the cycle. So the first part of the audit was performed in November of 2019 by Dr. Veronica Aquilina. Then together we outlined a protocol which was distributed among all of the radiographers working in MRI in January of 2020. Then a month later, in February, we repeated the audit. And now in November of 2020, we again repeated the audit to see if we improved the service, basically. So the results of the first audit cycle, out of the 100 scans that we analyzed, 21% of them had motion artifact. And of these 21 cases, 33% only were repeated. So then we devised this action plan, which was distributed amongst the radiographers. The first part mainly outlines the prevention, basically, because it reminds the radiographers basically that to instruct the patient to remain still throughout the whole of the scan, and even a second movement can cause image degradation. Then the first sequence was performed and evaluated. If motion artifact was noted, the patient was again reminded not to move, and to make sure that they heard our instruction again, they were asked to reply back through the speaker. Then the second sequence was then performed. If no motion artifact was noted, the first sequence was then repeated, and if motion artifact was still present, no repeats were done, and the note was written on RIS. The second audit cycle that was performed in February 2020 showed that the artifacts, the image scans with artifacts, were reduced to 19%, so we already saw a slight improvement. And of these 19 cases, 53% were repeated. So again, we saw an improvement in the cases that were repeated. So even for a month later, there was more awareness of being attentive to these motion artifacts. Out of these 19 cases, 37% had followed the protocol. And of these 37%, 5 cases were not repeated according to the protocol that we outlined. In 6 cases, the sequence with movement was not repeated altogether, and in 1 case, no radiographer remarks were noted down. In the final cycle that we performed, 10% of the scans that we analyzed had motion artifacts. So again, we saw a large improvement in the cases with motion artifact. And of these 10 cases, 70% were repeated. Of the scans with artifacts, 50% had followed the protocol and 50% did not. So when comparing this to the second audit cycle, we see an improvement with the adherence to the protocol. And when looking at the reason behind the protocol not being followed, 3 scans, they did not follow the protocol as we outlined, and in 2 scans, the sequence was not repeated altogether. So overall, when looking at the data, we see that the cases with motion artifacts had improved had decreased from 21% in the first audit cycle to 10%, and the repetition rates increased from 33% to 70%, and the protocol adherence again improved from 37% to 50%. Our aim of this audit was that we have 100% adherence to the protocol, so we still have not reached that, but as we can see, there's already an improvement overall after we outlined this protocol. Thank you very much.
Very good. Thank you very much, all 3, for presenting. I don't know if anyone from the attendees, if they want to ask any questions, feel free to use the chat or the Q&A if you have any questions. Just to confirm, Claude, we agreed that the questions were not going to be recorded. Is that correct?
Okay, I'm going to remove the recording.
Very good.
Stop the recording.
So people feel more comfortable to ask questions.